So all this is Dr. Mobeen Sayed from Drbeen.com. Welcome to one more show. So many of the cancer cells, they thrive and they flourish and they grow and increase because one of their capabilities is to evade our immune system so that our immune system cannot attack them and they just keep growing. And there are many mechanisms for how they evade and escape the immune system, how they suppress the immune system, how they mask and blind the immune system, how they create these cancer cells microenvironments within their own growth where they can have an immunosuppressant environment. So that all discussion is out of scope for this part of the video. What I wanted to discuss was when we were talking about mRNA vaccines 3 years, 4 years ago, one aspect of these vaccines was that, and I used to mention it when I would discuss the mRNA vaccines, that in the future we'll have designer vaccines or designer therapies for a specific condition in a specific person targeted by a specific intervention. And that intervention will be for that person. And for creating it, the person with the disease will be coming over or send their blood sample or tissue sample from where we would kind of discover what is unique about that tissue and create therapies that would attack only that tissue. And so not even other tissue within the same body, and of course not in the other bodies. So that was the designer intervention. And I used to say that this is what would happen in the future. So I believe that we are here with that future. We have now personalized vaccines against the most aggressive, one of the most aggressive cancers, pancreatic ductal adenocarcinoma. And the trials have amazing results. Remember that this is one of the most aggressive cancers. The 5 years survival is lesser than 10%, and recurrence is very high. The life quality is very, very hard with this cancer. So let's look at the therapy. So this is Drbeen.com. There is a link in the description of this video, which would give you access to amazing Drbeen.com medical lectures. Now, here is the BioNTech. That is the same one that is Pfizer-BioNTech. So BioNTech is the mRNA vaccine part. So this is their press release. 3 years phase 1 follow-up data for mRNA-based individualized immunotherapy candidates showing persistence of immune response and delayed tumor recurrence in some patients with resected pancreatic cancer. Very, very interesting outcome. So I'll explain how this works, but let me just show you some more references here. This is England's NHS. So NHS England has started a trial, as you can see here, thousands of NHS patients to access trials of personalized cancer vaccines. So NHS has invited thousands of the patients to say, come give us your tissue sample. We will create specific vaccines or specific interventions that would attack or have your immune system attack the cancer tissue only and your cancer tissue only. So of course, there should be a question in your mind right now that how would they train the immune system of a person to attack their cancer cells? And I'll give you a short answer, and that is that whenever we develop cancer, God forbid, the cancer has some specialized new proteins on it. Because the cancer cells mutate, the DNAs mutate, those mutated genes create some new kind of proteins that are expressed on the cell surfaces. We call them neoantigens, and I'll explain that a little later. We can, in the lab, identify those neoantigens and then train by making mRNA vaccines that can make the similar kind of antigens and then inject them in the body, which will make our immune system respond to those antigens and learn to attack them, and then go to the cancer, environment and go and attack the cancer cells and kill them. Very interesting mechanism. I was talking about it 3 years ago, so here we are. Here is the investigational mRNA vaccine-induced persistent immune response in phase 1 trial of patients with pancreatic cancer. Here, Dr. Vinod Balachandran, he is the principal investigator of this discussion trial that I would discuss today. And then there are some more references here as well. So with this, now let's see how does this work in general. So I haven't done a huge amount of drawings, but imagine that this is a cancer cell. So what happens is in this cancer cell, let's say this is pancreatic ductal adenocarcinoma, one of the most devastating cancers with the, as I said before, with the survival, 5-year survival rate of lesser than 10%. It becomes a death sentence, unfortunately. And it can happen to anyone. So here, let's say there is a change, there is a mutation. Of course, that is how cancers come into existence, that their genes change accidentally or for varying factors. Once the genes change, those genes would then cause the messenger RNA within the cell to be different. And those new protein types that will be produced can be displayed on the cell surfaces. These will be called neo standing for new, neoantigens. New antigens. Antigen, every protein in our body can be called antigen from the point of view of our immune system. Now what happens is our macrophages and dendritic cells, so here is a dendritic cell, they would like to actually attack this antigen because they've not seen this before. So they think it is a foreign antigen. So they would like to attack and kill the cell. And they actually do that to some extent. However, then the cells, the cancer cells, because they're growing from our own tissue, they're not foreign cells, they start convincing the immune system that, hey, don't attack me, I'm part of you. For example, one mechanism, just one mechanism, cancer cells can display a protein called PDL1, programmed death ligand 1. What this protein does is that when the immune system cells are becoming upset about this cancer cell and the foreign proteins and the changes in it, they would try to attack it, but this cell is now displaying PDL1 on its surface, which will then connect with the PDL1 on the PD on the other side, and it would tell it, this is like a break. It would tell the immune system cell to say, hey, calm down, don't worry, become exhausted, become tolerant to me. I am nothing new. I am nothing odd. Leave me alone. So this is a cancer cell telling the immune system cell to say, leave me alone. Immune system cell in turn will become exhausted, meaning it would become tolerant. It would become self-tolerant. It would say, okay, I will not attack you. I'll go away. And now this cancer cell and similar cancer cells would now keep thriving because they have created an immunosuppressant mechanism. So how do we help this patient? How do we help this cancer? And those aggressive cancers have this behavior. For example, pancreatic ductal adenocarcinoma. So in the past, what used to happen was there would be surgery done, there would be radiation, some chemotherapy. Even with those, the quality of life would go down. Even with all kind of interventions, at best, the life expectancy would go to 20%, mostly lesser than 10%. So this is the new one, the phase 1 trial that they did. What they did was the following. They took these cancer cells from the patient. So remember, this is designer therapy. So you have to have the tissue from the patient to create a drug that would attack that tissue. So they would first harvest some cancer cells and they would bring them in the lab. Now in the lab, they would study these abnormal proteins or neoantigens on them. And that is a difficult thing. You cannot just go in and say, all right, what are the new formed proteins? They have to actually see what kind of mutations are present. There are 20 most likely mutations that are present in the pancreatic cancers. So they start looking for those mutations. Once they find the mutations, then they figure out what is the genetic pattern of that mutation, because that mutation is causing a specific kind of a protein to be produced. So once they understand the pattern, they then And I'm simplifying it as they can do it, just, but this is a complex process. They then create this messenger RNA that has this pattern. That means when this messenger RNA will work with our ribosomes inside the cells, the ribosome will produce the same protein that the cancer cell is producing, which is unique to the cancer cell, and other cells are not producing it. Right? So this is a neoantigen, it's a new antigen. So when this antigen is produced, now this antigen is produced, let's say, in the immune cells, in the dendritic cells. What these cells would now do, so let's say there is a dendritic cell, I should make it all with dendrites. So this is a dendritic cell. It would help a T naive helper cell, and I have discussed this many times. It would present this antigen, which it produced as a result of vaccination, and it would present that to T helper naive cell. And then in the presence of interleukin 12, T helper naive cell would go the T helper 1 pathway, and T helper 1 pathway would then cause cytotoxic T cells to become activated. And these cytotoxic T cells, cytotoxic T or CD8 positive T cells, cytotoxic T cells would then go and kill, where was that cancer cell? Kill this cancer cell, because they would see these proteins present on the surface of the cancer cell. So once again, you would say that why did this not happen automatically? Because the cancer cells had created an immunosuppressant mechanism. And so when you sent that message from outside to say, hey, immune system cells, become sensitive to this specific protein, and wherever you see it, attack this, then an army of these will be produced and they would go and start attacking it. Now, what are the kind of results that are seen? So I think you'll be amazed with this result. Check this out. So this is 7 April 2024 is the result. 3-year follow-up data on an investigator-initiated phase 1 trial of the individualized mRNA cancer vaccine candidate called autogene Kevumirna or Kevumiran. So autogene because the genes are replicated from that person's own cancers, and then Kevumiran is the name. So what it does is continue to show polyspecific T cell response up to 3 years and delayed tumor recurrence in patients with resected pancreatic ductal adenocarcinoma. Very interesting. So up to 3 years, these polyspecific means that the vaccine or mRNA initiated multiple kinds of CD8 cells that could attack various protein. So let's say there is another protein that looks like this, and then there is another protein that looks like this, and there is this protein that looks like this. So polyspecific means some cancer cells are attacking, cytotoxic T cells are attacking here, some cytotoxic T cells are attacking here, some are attacking here. So these are polyspecific. So continue to show polyspecific T cell responses up to 3 years, and delayed tumor recurrence. Why? Because they are now running around in the body, and whenever that tumor cell grows, another tumor cell comes into existence with the same proteins, they go and whack it. Very interesting. A randomized phase 2 clinical trial with autogene Kevumiran in patients with resected PDAC is currently enrolling in the US. So there is a phase 2 trial going on in the US as well. The medical need in PDAC is high, with a 5-year overall survival rate of only 8 to 10%. High recurrence rates after surgery at nearly 80%, and limited treatment options. So then what happened? Today they announced 3-year follow-up. I want to show you the results. So let's look at the results. So there were 16 patients in phase 1 trial who received this therapy. Out of 16 patients, 8 of the patients responded to this therapy, and de novo T cells were formed. What does that mean? What that means is these researchers had taken the patient's blood before giving the vaccine, and they had a sample of what kind of T cells are present in this patient. Then they gave the vaccine. Then they looked at the blood samples again to see which kind of T cells are now present. And they found a large number of tumor killing T cells that had become produced that were not present in the patient's system before the vaccine. That means it was triggered by the vaccine, and these cells were tumor specific and they were killing the tumor cells. So these are de novo CD8 positive T cells, newly formed within the body, new T cells. Very interesting. So in 8 of 16 patients, autogene cevumeran elicited high magnitude T cell specific to the encoded neoantigens. 98% of the T cells targeting individual neoantigens on the tumor and induced by autogene cevumeran were de novo, in that they were not detected in blood, tumors, and adjacent tissues prior to administration of the investigation treatment. 98% of the immune cells that were fighting it, they were new. They were not in the. So imagine a person having cancer and is unable to create those cells that would kill the cancer. And now 98% of the cells that are killing the cancer have become generated after getting training from this mRNA. Then, over 80% of the vaccine-induced neoantigen-specific T cell could still be detected up to 3 years post-administration in patients with an immune response. Why is this interesting? Once you have gotten the immune suppression done, or tumor suppression done, tumor, let's say, removal done, you want to make sure that there is an army of the cells sitting there, and anytime a new tumor cell pops up, they whack it right away. So that's what they were doing for 3 years. These patients showed prolonged median recurrence-free survival compared to non-responders. So out of these 16, there were 8 who just did not respond to this vaccine at all. Their cells, there were no new T cells formed, and they're trying to figure out why not. Now, check this out. 6 of the 8 patients. So there were 16 patients, 8 responded, 8 did not. Those who responded, out of those 8, 6 patients with an immune response to autogene cevumeran remained disease-free during the 3-year follow-up period. We are talking about pancreatic ductal carcinoma, which kills within 5 years. Much faster than that, actually. Much faster than that. And here, after 3 years, 6 patients remained disease-free, while 7 of the 8 patients without an immune response to the treatment during the trial showed tumor recurrence. And so the remaining 8 who did not respond, which they are not sure why did they not respond, out of those 8, 7 had the recurrence of the tumor after resection and chemo and radiation was done. This huge is the response. Imagine you could target any cancer with these kind of genes, especially those cancers. For example, one of the issues with the pancreatic cancer can be that it could become non-resectable, non-surgically removable, because it is just so integrated with the remaining tissue. And imagine if you could find those designer proteins, those unique proteins on those cells, and then create mRNA that would create those proteins separately and train the immune system. So immune system goes wherever these cells are integrated and kills them. So an ongoing open-label, multi-center randomized phase 2 trial sponsored by Genentech in collaboration with BioNTech was started in October 2023. The phase 2 trial is currently enrolling patients at clinical trial sites in the United States, with additional sites planned to open globally. So then they talk about the pancreatic adenocarcinoma. I have discussed it. They call this technology iNeST, individualized neoantigen specific immunotherapy. So individualize for one person, neoantigen for their cancers, new antigens that are present on their cancer, the decorations that are only on their cancer cells, specific immunotherapy. So this is specific immune therapy. Nova says, be careful People, Dr. Bean is reading off a pharma press release as if it is a study. No, I am reading off of the mechanisms here, and with some results. It is true, it is press release, and the link is in the description as well, where they say that this is a forward-looking statement, and we cannot promise anything. They are just showing the results of 8 people with the 6 improving, and it is a phase 1 trial. I have already mentioned it, so there is no further announcement needed. Okay, so here, iNeST immunotherapies are investigational individualized cancer therapies tailored to specific patient's tumor. They contain unmodified, pharmacologically optimized mRNA encoding up to 20 patient-specific neoantigens, identifying using real-time next-generation sequencing and bioinformatic neoantigen discovery. So patient will have to send in their tissue samples. They would do the sequencing to figure out what is the mutated antigen in there, and then make mRNA to that. Neoantigens are proteins that are produced by cancer cells that differ from the proteins produced by healthy cells and are recognized by immune cells. So all of this is actually nothing to do with the press release. This is how the medical mechanisms are. By analyzing each patient's tumor, BioNTech is able to identify the cancer mutations that may act as neoantigens. Each individual cancer vaccine encodes for neoantigen candidates with the highest likelihood of helping the immune system recognize the cancer. For this purpose, BioNTech has developed an on-demand manufacturing process following good manufacturing practice conditions. I love it. So then here is the NHS. Give it a read. This is in the description as well. Some more comments here from the principal investigator that were interesting. I already talked about this one. I think we've already talked about it. Okay, excellent. So this is the discussion. I understand there are so I understand Luis, your point of view. That is how we all ended up with the hesitation. Anyways, this is a very, very interesting development, especially in the pancreatic cancer area, which is quite a deadly disease. I know some friends who had it and couldn't survive more than 6 months. So with this, thank you very much. Like, subscribe, and share. There are links in the description if you would like to support this work. There is also a link to get access to drbeen.com at a very inexpensive rate. And remember, I had said that I will tell the book giveaway. So the book for Friday, Saturday, and Sunday, and Monday subscribers, Keith Gabriel is the winner of the book. I would put that as a post as well. And so I would be sending this to Keith Gabriel when he gives me his address. So with this, thank you very much. And I would see you the next time. Bye for now.